moderator, Lauren.
Welcome, everyone, and thank you for joining us today for the first of the CECTR 2017 webinar series. We're excited to start off the year with the webinar series as well as the first in the methods training series. Before I turn it over to our presenter today, I just want to reiterate that for the Q&A session, we will be using the chat feature. So throughout the presentation, please chat in your questions. I will be keeping a parking lot of questions, and we will try to get through as many questions as possible in the time that remains after the presentation. I will be going through the questions in the order they came, and if any question is not addressed during the Q&A session, responses will be provided at a later time. So all questions will be answered. So without further ado, I would like to turn this over to our presenter, Dr. John Ioannidis.
Thank you for the very kind invitation. It's a great pleasure to present this webinar today. I will try to discuss issues of data analysis and interpretation as they pertain to observational studies mostly, with a bit of allusion to other types of designs. And the title, I have to apologize if it sounds a bit provocative, but it's actually a title that Howard proposed, and I couldn't say no. Be sure you're right, then go ahead. Sometimes we can be sure that we are right when it comes to data analysis interpretation. Many other times we cannot really be 100% sure that we are right, but we still have to go ahead one way or another. But at least we have to be aware and cognizant of what are the limitations in going forward and where that might backfire at some point, or how we may need to be cautious in interpreting what we have found. So the possible outcomes of observational analysis are very diverse, and usually, as we're dealing with a huge number of analyses that we perform often in databases that have been collected with no particular plan in mind, just collecting lots of data, or with a particular plan in mind, many of the analyses are likely to yield quote-unquote negative results, and they may well be negative. So these would be the true negative results. Null effects are very close to the null, with confidence intervals sometimes being pretty narrow if you have a large database, and still not being far from the null. False negatives are also a concern, and in many situations this has to be taken very seriously if what we might be missing might be of great importance. And there's no generic recipe for that, but one has to ask all the time, what if we have missed something here? For whatever reason, low power or some bias acting in the direction of creating a null seeming effect while there is some association, possibly even some effect. False positive correlations, associations, but no correlation really being present. I think that we see lots of that, and I will discuss why this is the case. True positive correlations, but no causation involved. There may be that we have some correlation, some association that is there, and it may have some information to convey, for example, for predictive purposes, but part of a predictive model, for example, but still there's no causation. It's not that if we could affect that factor, we could have an outcome directly affected for what the disease is, or what is the outcome of interest. And finally, these diamonds of true positive correlations that also mean causation. And obviously, this is the best that we can get. Many, many years ago, Bradford Hill put forth these 9 criteria for causation. He was very cautious in his wording when he published that paper, and he said that none of them is really perfect, and you need to consider them very carefully. And I will go through these 9 criteria during this webinar, trying to dissect in the current environment, not in 1965 when that paper was published, which set a background for epidemiological research for many decades, that currently in the type of research that we do with observational studies, what do these criteria mean and how could they be applied? The difference compared to 1965 is that now we have accrued a lot of data that we can analyze. There's more than 20 million authors of scientific papers and other scholarly documents. There's more than 160 million papers and other scholarly documents across all science and all times, and this is increasing at a pace of about 5 million per year at a geometric growth. The empirical papers are a very large share of them, and association studies, observational studies are a very large share of these empirical papers. Each paper nowadays is very different compared to what Bradford Hill was describing 50 years ago as calculations that you can replicate on the back of an envelope. Most papers we cannot reproduce on the back of an envelope. Some of them have millions and billions of potential results. There's a few of these millions and billions of results that are summarized within a few pages, and this gives us a glimpse of the multiplicity that might have been involved in some of these analyses. Here's one post-publication compilation of such studies. A couple of years ago, along with Jonathan Schenfeld, we decided to perform a cookbook systematic review of nutrients and cancer. So we opened the Boston Cookbook, which is a very popular one. It has been published since the 19th century, and we took a recent edition, obviously. We randomly selected 50 ingredients from the cookbook, from recipes, and then ingredients from the recipes. And then we went to the scientific literature and asked how many of these are associated with significantly increased or significantly decreased cancer risk in the scientific literature. This is what we found. On the top panel, you see the relative risks for one serving per day for different types of cancer for these ingredients and studies thereof. And in the bottom panel, you see the same depiction of relative risk for one serving per day for different ingredients like wine, tomatoes, tea, sugar, salt, potato, pork, and so forth. And you see that almost always there's action on both sides of the null, which is the vertical line at relative risk of 1. There's a few ingredients that always do poorly, like salt is always on the bad side, and bacon, or must be somewhere there, right to see, is always on the bad side, more or less. But more common scenario is that you will see action on both sides. And if you think about how big are the relative risks that are expected to be seen with these nutrients, it's unlikely that any of these estimates are close to the truth. So I believe, as a prevention professor, that too much salt is not good, that too much processed meat is not good, that fruits and vegetables are good. So I would expect these effects to be different from one, but the best studies that have been done suggest that the relative risk for all cancer incidents for fruits and vegetables are in the range of a relative risk of 0.999 per serving per day. So if you see a relative risk of 2 or 3 or 5 or 0.7 or 0.8 for these types of studies, it's extremely huge. It doesn't make sense. A relative risk of 0.5 means that with 2 more servings per day of fruits and vegetables, we would practically eliminate cancer because we would get rid of 75% of the burden of cancer. If you take a closer look at these studies, you see that practically almost all ingredients are associated with cancer risk, 40 out of 50, and even the 10 that are not listed here, it's just that our search was not sensitive. So vanilla is not listed here, but if you search for vanillin, you will find studies that suggest an association with, I don't know, increased risk, decreased risk, maybe both. Usually it's both. And if you look at the p-values and how they map in terms of standardized z-scores from the normal distribution equivalent, you see that green color distribution, which is the z-scores or p-values of the main effects that are presented prominently in these papers, like in the abstract, and you see that there's a lot of missing space in the middle from -2 to 2, which is the range of non-statistically significant result for a threshold p-value of 0.05. based on the effect sizes that we're chasing, which are relative risk of 0.999 or 1.01 or less, we expect almost all of these studies, which have modest sample sizes most of the time, to have yielded negative results, in that middle ground. But negative results are not attractive. Probably they're suppressed or modified, or people continue exploring analytically until they find some significant result. If you look at the full text and unearth some additional important outcomes that were not presented so prominently, but they're in the fine print, you get that gray color distribution, which starts filling some of the middle space, which means that there are some negative results that simply get buried in the fine print, but still there's still a missingness in the middle ground. If you perform meta-analysis trying to put all of these data together, some of the middle ground starts filling up, so some of the high-risk and low-risk studies start canceling out, but there's still missingness in the middle. So not even meta-analysis can really fix this. Here's a typical situation of what is going on if you take a look at a whole field of risk factor epidemiology. This is an analysis of all the studies that we could find on risk factors for pterygium. And what I have done for you here, along with my colleagues, Stelios Sergiou and Chirag Patel, we mapped all the risk factors that have been considered. And this is just a snapshot of many, many more risk factors that have been considered, and far more granularity in the way that these factors are defined. The different colors mean that these factors have been studied with different models, with unadjusted analysis, with adjusted analysis, with both unadjusted and adjusted, with different types of adjusted analysis, and they also yield very different results. So there's not two studies that have looked at the same set of risk factors. Each one is looking at a very different space, using very different analytical models, very different model specifications, and getting almost chaotic results that it's very difficult really to make sense if you look at all the studies together. If you look at a single study, it makes perfect sense. If you look at all of them, it makes very little sense. This is getting more and more complicated in the current research environment because we have more and more data. Our ability to collect and analyze data is growing exponentially. Big data is the great bandwagon and catchword at the moment. But big data provide both opportunities and challenges. All of the problems of false positives or biases can be magnified in big data, so we may end up only with big noise and big error much of the time, although I don't want to discredit that big data are not offering us some useful information sometimes. The question is, how do we separate that useful information from the big noise and the big error? So let's run through the 9 criteria in the current environment and see how they work or they do not work. Bradford Hill describes strength as the most important one. First upon my list, I would put the strength of the association, the magnitude of the effect size, either in a standardized effect or an odds ratio or whatever. In thus putting emphasis upon the strength of an association, we must nevertheless look at the observer of the coin. We must not be too ready to dismiss a cause and effect hypothesis merely on the grounds that the observed association appears to be slight. There are many occasions in medicine when this is in truth so. So he was very cognizant of that danger. And at that time, some of the risk factors that were being discovered, like smoking causing cardiovascular disease or smoking causing lung cancer, the effect sizes were huge. So strength was clearly there. But in the current environment, most of the effects that we're after, most of the associations that we're chasing, most of the true ones, are likely to be pretty subtle. There's many of them that are very, very subtle. And this is an empirical evaluation that we did where we tried to map small and tiny effects with odds ratios less than 1.05 or bigger than 0.95. And you can read the paper if you wish in more detail, but practically there's a lot of risk factors and also interventions, so not just in observational research, but also in randomized trials that have highly statistically significant tiny effects. I mentioned fruits and vegetables with relative risk of 0.999. It is there, and it may have public importance to know about it and to even inform public policy. But if we are going to chase these tiny effects, we cannot really use strength as a criterion. Actually, if I see a huge effect in my own data, in my own analysis, which I do almost every day, I almost know for certain that it's false, because otherwise, why am I the first to discover it? I mean, there's so many smart people out there. If I come across an odds ratio of 13, I go back and check the data, and I realize most of the time that I've made some error in the calculations, or some of the data were not clean, and I got it completely wrong. So are there any large effects still out there? Maybe a few. And since it's very difficult to look at the entire observational literature, this is an exercise that we did with the entire randomized controlled trial literature. Well, not exactly entire, but about 50% of all randomized trials that have been done. We went to the Cochrane database and we analyzed close to 250,000 randomized clinical trials and 85,000 meta-analysis for any type of interventions. Large effects, meaning very large effects, odds ratios over 5, were pretty common. About 1 in 10 studies had an estimate for an outcome, a point estimate, that was an odds ratio of more than 5 or less than 0.02. However, whenever we performed another study on the same treatment in the same population or similar population, these effects went away. They either completely disappeared or they became much, much smaller. At the end of the day, there was only one treatment effect in that huge collection that pertained to mortality, had been validated in several trials, had a p-value less than 0.01, and was very large and had been seen repeatedly. It's not that there's not any others, and maybe some of the most effective interventions have never been tested in observational studies, but clearly large effects are unusual. If you come across a large effect, you need to question yourself. Why did I get this? It's very likely that it's spurious. Sometimes effects are not completely misleading, but they're just larger than they are in reality when we detect them. So this is the winner's curse phenomenon, and it's very common in very different types of research where it has been documented. Here's one example from biomarker studies in biomedical literature. These are the most highly cited biomarker studies that have been done. And I'm showing you the relative risk in the most highly cited study and the relative risk in the largest study that was done typically subsequently. You see almost all the action is below the diagonal, which means that the first study that attracted the most attention and got most impact in the literature for CRP, for example, suggested an odds ratio of 4 or more. And currently, the largest study suggests a relative risk of 1.3 or so, and no causal effect for association with cardiovascular disease. Consistency. This is the wording from Bradford Hill's paper. Has it been repeatedly observed by different persons in different places, circumstances, and times? And again, he's very cautious. Once again, looking at the obverse of the coin, there will be occasions when repetition is absent or impossible, and yet we should not hesitate to draw conclusions. So indeed, we cannot wait for replicating everything, but in the last several years, because of the brewing non-reproducibility or irreproducibility crisis, many scientific disciplines have decided to start taking a look at what we have believed and what we have done in the past, and we get lots of inconsistency, lots of irreproducibility when we do that. There is an emphasis of shift towards replication. About 20 years ago, a paper was published in Nature saying that TNF-alpha genetic variants are associated with cerebral malaria. It got cited more than 1,000 times since then. And if you look at the first 100 citations to that Nature paper, about 50% of them were the blue color, which is no data papers, like reviews, editorials, letters, and news. Then there were a few methodological studies that cited that work. There were several studies that were evaluating different genes, others that were evaluating different diseases, and many that were evaluating both different genes and different diseases, and were using the Nature paper as support for making a claim that, that variant was seen to be associated with cerebral malaria, and therefore now we describe an association with stroke and so forth. None of them were replications. Red color, replications, not visible, none of them were replications. So after about 600 citations, someone tried to replicate that study, and the effect was entirely null in a population that was 10 times larger than the original Nature paper. And then there was another replication, even larger, again, no effect. Based on what we know now for candidate gene studies, this is not surprising, but this is one example on how some fields had no replication for a very long time. Some of them have changed, so genetics uses replication consistently nowadays, like in this case, where genome-wide association studies create consortia of investigators that test the same phenotypes and genotype-phenotype associations across all the teams, and you see that a pattern is consistently replicated. But many other fields in observational research, not only in medicine, but in many other fields, don't have yet this strong paradigm of collaborative research, sharing information, trying to replicate rigorously what is observed in a single team across multiple teams. Even when we have replication attempts that refute an original observation, there's still resistance to refutation. And even when we have some very rigorous randomized trials testing some observational effects that were very promising but eventually don't pan out, there is resistance to refutation. These are some citation analysis, for example, on what happened to the citation profile of the paper published in Nature on the effectiveness of beta-carotene in cancer prevention. Highly cited paper published in 1981, and then heavily cited, heavily influential. Then we had 6 randomized trials with very large sample size, no effect at all, no benefit at all. Nevertheless, the citation rate for the original paper that said that beta-carotene is a chemopreventive agent continued to be extremely high, much higher than the average Nature paper published in the same year, 1981. And the reason for that is not that people were citing the original Nature paper to say that it was wrong, but they were citing it to still defend why they're continuing to perform research on beta-carotene for different applications in cancer. In the case of estrogen for prevention of dementia, it's a similar pattern. It was not that the citation rate was even higher than the average paper published in the same year, but again, refutation in multiple randomized trials didn't really decrease the rate of citations of that paper. And in that case, it was not that people ignored the randomized evidence, but they came up with lots of possibilities on why the randomized evidence was not to be trusted. And some of them may be fair, but at the same time, these randomized trials cost like $1 billion. They took many, many years to design. Everybody put their best effort to do them. They were clearly well done. And I think that it's more likely that the original observational documentation was not correct. But as you see, there's no end to a debate once it had started, which means that we may need to be a bit more cautious in trying to make original claims about associations, and especially implying that they have causation in their effects being involved. Specificity. Again, the wording from Bradford Hill, one reason, needless to say, is the specificity of the association, the third characteristic which invariably we must consider. Again, he's cautious. We must not, however, overemphasize the importance of the characteristic. One-to-one relationships are not frequent. Indeed, I believe that multi-causation is generally more likely than single causation, though possibly if we knew all the answer, we might get back to a single factor. I think that here he goes really way into the future, and he sees where we stand now, because indeed, we are in a mess of causation, in a mess of correlation. These are data from the Singapore prospective cohort with measurements on 19 nutrients and seeing what their correlation pattern is. As you see, almost everything is correlated with everything. And then these are data for NHANES, correlations between triglyceride levels and various exposures. Many exposures are correlated with triglyceride levels. So you see a connection, there's some association, some correlation there. But which ones of those are causative, that's really very hard to tell. If you go a bit further and try to assess both risk factors and intermediate outcomes and clinical outcomes, here you have daily intake for 3 nutrient variables, fruits, total calories, and meat. You have a number of intermediate variables like triglycerides and insulin and creatinine. and you have a clinical outcome like diabetes, still lots of connectivity. Is that specific? That's clearly non-specific. There's very little specificity nowadays in the research that we do. People looking for a silver bullet, good luck. I think it's very, very uncommon that we see that in epidemiology. And this creates a lot of confusion sometimes. Here's one example where we have analyzed data from NHANES for the correlation between smoking measured as cotinine levels and other exposures. There's blue and red color reflecting positive and negative correlation, statistically significant, highly statistically significant, and there's tons of such correlations. So smoking clearly is killing so many people, and it's doing that for so many pathways and for so many diseases. So all these other factors like carotenoids, for example, or vitamin B or vitamin C, and so forth, if you run studies without taking smoking into account, you're likely to see some association with many other diseases just for the fact that they are correlated with smoking for one reason or another. Not causative, of course, but still correlated. So specificity becomes even further blurred in that environment. And this is another look of 4 such factors. Cotinine is the first one on the left, but I'm also showing you mercury, cadmium, and beta-carotene. And if we focus on beta-carotene in these NHANES data have 68 very strong correlations with other exposures. So it's not surprising that people thought that beta-carotene would be such a great intervention based on observational evidence. It would correlate with almost anything that you can test it against, and therefore maybe it was just an easy, spurious finding to come across. Temporality, the temporal relationship of the association, which is the cart and which is the horse. Sounds very simple, but still a caveat, these temporal problems may not arise often, but it certainly needs to be remembered. Can we document temporality in the broad sense if we take a bird's eye view on the current observational research that we perform? Sometimes we can. I mean, we have an increasing reliance on prospective cohort studies as compared to case control studies and other retrospective designs. But still, if you look at many diseases and their risk factor epidemiology corpus, most of the time it's not easy to tell which one is the cart and which one is the horse. So this is from a paper that we published recently where we reviewed all the epidemiological literature on Parkinson's disease. And I'm showing you here risk factor associations that have highly suggestive evidence. They are supported by a lot of studies with large sample size, and the effect sizes seem suggestive. Their p-values are less than 10 to the minus 6. Sometimes they're 10 to the minus 20 or so. However, if you look carefully at them, almost none of them you can be sure about the temporality issue. So anxiety or depression, does it cause Parkinson's disease, or is it that subtle symptoms that predate the official diagnosis of Parkinson lead to anxiety and or depression, then Parkinson makes these worse? Physical activity, is it that physical inactivity leads to Parkinson's disease, or is it that people who have these early development of these pre-diagnosis symptoms also limit their physical activity, and so forth. Biological gradient. This is the statement. If the association is one which can reveal a biological gradient or dose response curve, then we should look more carefully, most carefully for such evidence. But the comparison would be weakened, though not necessarily destroyed, in the absence of dose response. This is a very interesting criteria. It means that we're trying to establish some model about how the variable of interest is associated with the outcome of interest. Model building in epidemiology, though, is very precarious. And not only the shape of the variable, how do you express that? Do you express it in categories? Do you express it in a log scale? Do you express it in 5 categories, 10 categories, 8 categories? But also what other things you build in the model to try to adjust for that, and whether you consider interactions and what kind of interactions. This will give rise to a very different range of models. And once you have a range of different models for attacking the very same question, you can get a range of very different results. You get what I call the vibration of effects. And the dose response may be manifest in some of these models, but it may not be manifest in other models. In many cases, when we test too many models, we can get what I call the Janus phenomenon. Janus was a Greek-Roman god. He could see in both directions, in opposite directions, and this is what we get if we analyze too many different models for the very same data set. These are, again, data from NHANES, and I'm showing you a cloud of about 1 million results of the minus log 10 p-value and the hazard ratio on the horizontal axis of whether creatinine is correlated with the risk of death and whether alpha tocopherol is correlated with the risk of death. The way that I get these 1 million models is that I try to adjust or not adjust for 19 different variables. So you have 2 to the 19 different choices. And you see that eventually, if you create more and more models, almost everything will look like that V-shaped Janus phenomenon. You have 70% of the data for alpha tocopherol suggesting that alpha tocopherol decreased the risk of death, and 30% of the results for the very same data set suggesting that alpha tocopherol increased the risk of death. If we just report one result, this may be highly misleading and not representative of that universe, that cloud, that cluster, that galaxy of results. Plausibility. It will be helpful if the causation we suspect is biologically plausible. However, this is a feature I'm convinced we cannot demand. What is biologically plausible depends upon the biological knowledge of the day. So epidemiology and biology are moving hand in hand. Sometimes the epidemiology is more reliable, sometimes the biology is more reliable. Based on what we know now, we know that much of the epidemiology that we thought we knew in the past is not reliable, and much of the biology that we thought we knew in the past is not reliable. Who knows what will be the case, let's say 5 years from now, about what we think that we know now. I think that biological plausibility, unfortunately, even though it's a very interesting criterion and sometimes it may really help, it can be misused. And it can be misused especially when we come across explanations that are post hoc and people are trying to justify why they're seeing what they're saying after a series of data dredging or bifurcating analysis. So this is one example of an exercise that I did a number of years ago. I took a single year in PubMed and I looked for studies that claimed that they found an association between ApoE epsilon polymorphism with various diseases. Now, ApoE epsilon polymorphism, we knew back then, and we still know that, it has a very strong association with Alzheimer's disease. Clearly documented, hundreds of studies, a relative risk of 4 or so, one of the big ones. However, within a single year, there were all these diseases claimed to be associated with ApoE epsilon polymorphisms, and there was biological plausibility invoked using the evidence from Alzheimer's disease to say that spontaneous abortion is pretty much the same, or nephrotic syndrome has some similar biology, or chronic pancreatitis has some similar biology, or diabetes has some similar biology with Alzheimer's disease. And you know, obviously, anything can have the same biology as anything, but what does this mean? This is another example from microarray studies. We screened 46 studies on microarray experiments addressing major cancer outcomes in humans, and we went to the discussion and scrutinized the comments that were made about external evidence that, according to the authors, supported or was against the findings of specific genes or groups thereof in the identified molecular signatures. Now, these risk factors, these molecular signatures, are built out of dozens, if not hundreds, of different genes. So you would expect that if someone were to discuss what does that signature mean, they would probably want to ideally be fair and cover all the genes, or at least a representative sample. And since there's no space for that in the discussion, one would hope that at least, since we cannot talk about 87 genes, we will talk about a few of them, and they will be genes that are in the signature, and they're also involved in previous studies for the same disease. However, only 17% of the comments did not even pertain to the same gene as found in the study, even though there were so many to talk about. People used to select, get a different one, and 53% did not pertain even to the same disease. And eventually, almost all the comments that were made were supportive for the research findings. 270 supportive findings versus 29 comments saying that some previous study had found a different pattern for that gene. So everything seemed to be congruent based on what we know for the microarray signature literature of that time, which is the prehistoric era. We published that paper in 2007. That's the prehistoric era for that field. We know that almost all of those were probably false or exaggerated. So out of false results, you can still find 90+% supportive comments to support them with biological plausibility. Coherence. On the other hand, the cause and effect interpretation of our data should not seriously conflict with the generally known facts of the natural history and biology of the disease. I have to say that that criterion I have big trouble with. What is generally known facts of the natural history and biology of the disease? Who is going to tell us what is generally known? Well, sometimes there's some consensus, maybe there's guidelines, but maybe there's review articles, but we all know that sometimes we can trust them, other times we cannot trust them. I go back to the pterygium example. If you read the classic reviews articles, there's 10 risk factors that pretty much all reviews feel that they are important to consider, like occupation, education, income, and so forth. Do people adjust for those? Not really. I mean, this is a snapshot of some of the studies that have been done. None of the 60 studies in pterygium risk factor epidemiology adjusted for all of these factors. Most adjusted just for one or a couple. And there's not 2 studies that adjusted for the same pattern of these background, quote-unquote, classic factors. So what is known can be quite debated in many fields. Most fields do not really have solid knowledge like smoking causes cancer. They have subtle effects that there may still be some substantial uncertainty. Experiment. Occasionally, it is possible to appeal to experimental or semi-experimental evidence. Here, the strongest support for the causation hypothesis may be revealed. And of course, this has not changed since then. I think that we do have the benefit of having some randomized trials that can assess some of the proposed correlations or associations that we see in observational studies. Sometimes we also have the benefit of comparing randomized trials against observational data that predate them. Here's one example where we compared randomized controlled trials on interventions versus studies with routinely collected data that predated them at a time that no RCTs had been done. And we see that the results are completely off. The relative odds ratio on average is 1.31, which is larger than the average effect that we are chasing. These are interventions for treatment. The typical treatment effect usually is an odds ratio of 1.2. So the noise is larger than the signal in that case. Very often for observational associations, we cannot even do randomized trials. So there may be things that are harmful, that cause death, that are high risks of being harmful, and therefore a randomized trial would be unethical. Do we discard them? Of course not. We need to use them, and actually we need to be very careful to make sure that we do capture all the possibilities of harms and not discard them, but we still have to be cautious about how we interpret them. Even randomized trials can be contradicted. So 5 out of 6 of the most highly cited observational studies were contradicted by larger and or better controlled, like randomized trials that were done subsequently. But even randomized trials, about 25% of the time, even the most highly cited ones do get contradicted by larger, better done randomized trials in the future. So I'm not trying to distill too much uncertainty here, but just to take into account what is the expectation of a given type of study design to give a solid evidence. You know, a randomized trial probably is doing better than the average observational data set, but still it's not a panacea in all cases. Analogy. In some circumstances, it would be fair to judge by analogy. With the effects of thalidomide and rubella before us, we could surely be ready to accept slighter but similar evidence with another drug or another viral disease in pregnancy. Analogy is in the eye of the beholder. It's a very nice criterion, but it depends on how people want to interpret analogy. So some medications probably increase the risk of cancer. I do believe that. But should we use analogy to extrapolate and say that, wow, then maybe many medications increase or decrease the risk of cancer? So here's one example. This is an analysis where we took the entire population of Sweden, more than 9 million. We used the medication registry that is more than 99% complete, a recording of all prescriptions across the country. The cancer registry, again, 99% of cancers are recorded. And we addressed all the possible associations of all medications against cancer risk. We could study 559 drug classes at the same time. And this is what we got. 1/3 of known medications may affect cancer risk. Actually, in this analysis that I'm showing you here, almost all of them decrease cancer risk, which is very weird. It would mean that if we take it seriously, then people should start taking any type of medication almost to decrease their future cancer risk, which makes absolutely no sense. Some of them increase cancer risk. If you look according to cancer and medication classes, 3 out of 4 medication classes may affect cancer risk. And the p-values sometimes are p-value 10 to the minus 100. So what does it mean? How are we going to use analogy here? We need to think very carefully about how we extrapolate the fact that we have seen some medications like immunosuppressants that may lead to secondary cancers, for example, versus extrapolating that, wow, here's another medication and therefore it does cause cancer or it does protect from cancer. There are some fields that are probably what I call null fields or scientific bubble fields. And actually, these may be the fields that have the highest proportion of statistically significant claims. These may be the least reliable. This is a paper by Dan Fanelli, who's currently a senior scientist at our metrics center at Stanford. He pointed out that some fields like psychiatry and psychology, they always report statistically significant results for what they claim to be the primary hypothesis, as opposed to space science, for example, that only about 2 out of 3 of the published papers do that. A few months ago, we looked at the entire biomedical literature, more than 10 million papers in PubMed since 1990, and also close to 1 million papers that we could look at full text. The others, we could look at the abstracts. And 96% of the biomedical literature claims significant results. So almost everything is statistically significant. The reassuring news is that the rate is going down. So it's gone down from 98% to 94, 95% currently, but it's still extremely high. This probably suggests that there's a huge selection of reporting significant results, eventually making scientific discovery of yet another new significant result just a boring nuisance. We just have millions of significant results, but only some of them are likely to be true and only fewer of them are likely to be useful. To summarize, strength, large effect sizes are almost always due to error and bias nowadays. Causal effects are far more likely to be small or tiny, so don't discard small and tiny effects. They may be just what we're looking for. Consistency. Consistency in replication, I think, is very important, and false non-replication or perpetuated fallacies are possible. So again, it doesn't mean that if we cannot replicate something that it is necessarily false, but also sometimes if we do replicate, but we have perpetuated the same biases, we may just have a perpetuated fallacy. Specificity, causal effects, based on what we know, are probably rarely specific. So we can't really use that criterion very reliably. Temporality makes perfect sense, but very often it's very difficult to document and to model. Biological gradient. I think it's unclear what this means much of the time. And I think that we don't know, and I have no clue why nature should behave in a linear or stepwise terms or otherwise. You know, in the absence of other evidence, I really cannot pick a model. Sometimes we may have some clues about what the model might be, but most of the time we don't really have that background information. Plausibility. In most cases, evocation of plausibility has been misleading because it's done post hoc. If people want to use plausibility, I think that they should do it in a pre-registered report. They should say that, you know, here's the hypothesis that I'm looking at. This is specifically the analytical model that I'm after, and this is the biological plausibility that's supporting it. Then you just put it in public, and I trust it. But plausibility after the fact, all the research that I've done is highly plausible, and probably most of it is wrong. I have to find some plausibility explanation to convince you that what I'm doing is correct, but it doesn't mean that it is correct. Coherence, largely unclear what it means. Sometimes useful, but usually not. Experiment, I think it's still the strongest of all criteria, and most epidemiology to date has been misleading because of failing experimental validation. But even for experiment, we cannot be certain that it is correct. So there may be cases where epidemiology may be correct in the observational data and the experiments may be wrong, or obviously vice versa, or both may be wrong, or both may be correct because of reasons that make them really different. And finally, analogy. In most cases, the evocation of analogy, unfortunately, has led to creation of bubbles of low-yield, self-perpetuating disciplines that are very difficult to get rid of and that yield very minimal information. So here's the summary in another view, the criteria and whether they work. Strength mostly doesn't work, and possibly you need to think of it even in an opposite fashion, going after small effects. Consistently, mostly yes. Specificity, mostly no. Temporality, yes, but rarely documented. Biological gradient, unclear. Plausibility, mostly no, but possibly even detrimental, the way that it's used nowadays. Coherence, unclear on how to operationalize. Experiment, yes, and analogy, mostly no, and possibly even detrimental. To conclude, in the current research environment, several of the criteria that have been traditionally used to assess causation in observational data have little predictive ability for causality, and some of them even decrease the probability of causality. There's no replacement to thinking very carefully both about the data and their interpretation. And this is exactly what Bradford Hill said 50+ years ago. This is exactly what we need to continue doing as epidemiologists and as methodologists. One should carefully consider also the implications of a false answer. So I'm not saying that we should use criteria as a way to destroy our findings. And we should be careful because sometimes even some seemingly completely null results may actually be false negatives. So we have to ask, what would it mean if we get it wrong? If we get it wrong because we have a false negative, and if we get it wrong because we make a false positive claim. And the implications may have different weight and different portent in each case. Randomization, whenever feasible and ethical, I think should be seriously considered. And I think that there's lots of people who argue that we should get rid of randomized trials, especially now that we have precision medicine, precision health, and individualized, and why wait for randomized trials? I'm still a believer in randomized trials. But randomized trials also have their own caveats, which we could probably talk for another series of webinars, and these could be many. So again, they're not 100% proof that we have settled a question, although very often they're getting us as close to that as it can ever possibly be. I think that this is all that I had to cover today, and I will stop here and wait for questions. Thank you.
Thank you very much for that wonderful presentation. I'm going to give everyone a couple moments to gather their thoughts and kind of continue to send in any questions you may have. And while we wait for questions to come through, if we could put up the announcement for next week's webinar. It'll be the second in the methods training, and we'll be joined by Dr. John Zammit for his presentation, Epidemiologic Training and Methods to Analyze Tobacco Exposure and its Respiratory Effects. As a reminder, this webinar will start at 1 o'clock. Registration is open, so please register. And it looks like we have a question that has come through.
Is it the question that I see in reference to model building?
Yes, in reference to model building, it's precarious. In reference to model building is precarious in epidemiology. Could you give your opinion on matching approaches as a way to reduce model dependence, the range of models, analyst bias, and reporting results from overfit models in observational research?
That's a very interesting question, and it covers probably multiple questions within the same sentence. there's an issue of overfit. And there's many ways that one can try to reduce the impact of overfit in the data, and that could be a series of seminars on its own. Then there's an issue of selectivity and transparency in model building. And here I would differentiate between two main scenarios. One is when we know what we're looking for, and we have a very specific question, and we know exactly how we want to address it. One reason why that might be the case may be that others who did some exploration before and have published some exploratory results have put forth that hypothesis, and now we need to validate. In that case, I would argue we need to be very specific about the model, why we choose it, and how exactly we plan to analyze the data. And ideally, there should be pre-registration of that protocol and analysis plan. And then you have that very specific model being analyzed, you get the results, and everybody says, that's what you promised to do, and this is what you do. Even a step further, in some scientific fields like cognitive sciences and brain sciences, many journals, about 50 journals starting with Cortex a couple of years ago, they have registered reports, which means that not only they register a protocol, but they also have the paper accepted by the journal, reviewed and accepted, without having the results with the explicit numbers, but having the results fully written, because the only thing that needs to be inserted is the numbers after you run the exact analysis that have been promised in the protocol and the method section of the paper. The second scenario, which is the most common one, is when we are in the exploration phase. And then I think one has to be entirely honest that these results came out of exploration. I did data dredge. I data dredge all the time. One has to be honest about it, that this is an exploration, and you have to take that very cautiously. Now, as part of the data dredging, I think that there could be a systematic effort even for data dredging. So what I showed you with these clouds of 1 million different models and 1 million analysis is one way to do it, which means that you explore all possible models. You have no preference for one of them for some very serious reason, and you give that vibration picture of how much the results differ. There's different ways to do that. There's Bayesian averaging. There's other tools that are used in usually narrow disciplines, but I think should be used more widely. So instead of just reporting one result, show the full range of sensitivity analysis that one could do and the range of different results that could be obtained if you explore that space of different options.
Thank you very much for that response. Just going to give it one more moment to see if there's any other questions coming through. And I do want to note that I apologize for the incorrect title for next week's webinar series. Alicia is chatting the correct title to you all now. So please look out for that. But the rest of the information was correct. It is next week, 1 o'clock, and please register. We are coming to the end of our time. If you have any additional questions, please feel free to submit, and we will have those addressed offline. Thank you to our presenter, Dr. Ioannidis, for his wonderful talk, and thank you all for joining us. One other note is that there will be a poll at the end of this session. Please, if you could take a few moments to answer those questions, it would be greatly appreciated and help us to continue to improve the webinar series and address your needs. So thank you all again for joining us, and we hope to see you all online next week.
Thank you.
We have a few more minutes on the poll. Once you've completed the poll, feel free to sign off, and we hope to see you again next week. Thank you.